Okay, folks, first of all, I want to apologize to you that we're running late. We had a longer day over there today than I think we had anticipated when we set this meeting up. But we're going to go ahead with our meeting, and some of our members are going to be sort of drifting in. They had some other obligations and some things, but we should have some more coming in. I want to welcome you all for coming and your interest in what we're trying to do. We have this room for 2 hours. My intention is to try to hear from everybody who has signed up, and just to let you know, we've got 25 people who want to be heard, and we plan to do that. But let me sort of throw out some ground rules before we get started, and I'd like to ask for your help to make sure we give everybody an opportunity who wants to talk to be heard. I'm going to ask you to speak for no longer than 5 minutes, and brevity is appreciated. And what we'll do is ask you to come up and identify yourself, and then talk to us. And Lauren Ashley, our intern right here, is going to be keeping a clock to keep me on schedule. And we're going to give 5 minutes. And when you get to the 1 minute mark, she's going to hold up her sign that says 1 minute, so you'll know that it'll be time to sort of wrap up your remarks and give you an opportunity to do that. But I really do need your cooperation so that we can be respectful of everybody's time and give everyone who wants to be heard an opportunity to be heard. And what I'm going to do is go down the list, and I'm going to call 2 names at the time. First on our list is an example, John Howell with the Georgia GHCA. Second will be Dr. Rick Weary. So we're going to call John first, and then Dr. Weary will know that he'll be second, and we'll do that to give you an opportunity to sort of get ready. But we'll ask for your cooperation, and John, we're glad to have you here, and you got 5 minutes.
Yes, sir. Thank you, Mr. Chairman, distinguished members of the committee. I'm John Howell with the Georgia Healthcare Association. We're the trade association that represents the nursing homes, some assisted living members, and a home and community-based services group called SOURCE. The presentation that Sarah has just passed out to you are 7 slides that I'll walk through very quickly with you, just to give you an idea of what's going on with the age-blind and disabled population, and I'll really keep my remarks limited to the nursing home industry because we applaud the governor. He has exempted hospitals and the home and community-based Medicaid portions of the budget from the cut. So the first slide that you have before you is really a depiction of the historical FMAP, Federal Medical Assistance Percentage, of a 60-40 breakdown. The state putting in 60% and the federal government doing 60%. Well, in 2003, the nursing home industry passed the nursing home provider fee. You now see that it only takes 23 cents on the dollar from the state to draw down the federal and the provider fee portion of that. That is good news and bad news. The good news is it only requires a smaller state investment to make that happen. The bad news is when you make a state cut, it's actually a larger cut because of the power of that state dollar in drawing down the federal piece. Really, that's really about jobs. It's about this sector. This long-term health care is 1.1% of the gross domestic product in this country. And so we actually employ more people as a sector than Walmart across the country. So if this is about jobs, if this is about an economic impact, this is a sector that has a big part to do with the economy. The next slide is just to show you the Medicaid shortfall. That is $6.62 that we are reimbursed below our cost. For an average patient, that's $3,100 a year. For an average facility, that's $250,000 that they're in the hole by taking Medicaid patients in their facility. The next slide is a depiction of what our southeastern neighbors are doing. These are not the states across the country that have the highest rates. You'll see that these are limited to the southeastern states. States like Florida, Mississippi, and Alabama are receiving $61, $38, and $31 more per patient day than we are here in Georgia. And Georgia, of course, as you can see on your slide, embarrassingly enough, is at the bottom of that list. The last chart that I've got for your consideration is to show you what's going on in the Medicaid utilization over the last 10 years. It's reduced dramatically. You can see over 10% over the last 10 years. And why that's important is really laid out for you on the next slide that shows that we've reduced Medicaid days by 100,000 days in FY 2010 at an average rate, which you saw was $139 for a Medicaid patient in a nursing home. That saves the state $3.7 million in reduction of utilization, which I think is a very key point. The last slide is really the ask is to show you that by using that reduction in utilization, we're saving the state the exact amount. It's not meant to be that clean, but we do have a $3.7 million cut, or 1% cut to Medicaid for nursing homes. I actually had 4.2 earlier in the week, and the House Budget Office helped me get my number straight. So the number wasn't exactly 3.7 to 3.7 earlier in the week, but it's nice that it works out that way. It has a $10.9 million economic impact to restore that cut. The remainder of those numbers are what the state plan amendment says or states how our program is to be funded. And we realize that the economic downturn has made that very difficult, but we'd be remiss if we didn't ask for that funding for our patients. But the immediate need is to restore the 1% cut. And with that, Mr. Chairman, I'll pause for questions.
Okay, we've got a minute or so. Anybody got a question for John? Okay, thank you very much. Appreciate that. Next, we're going to hear from Dr. Weary, and then after Dr. Weary, Dr. Fincher will be next.
Chairman Parrish and committee members, I really appreciate the opportunity to be here and testify before you today. My name is Rick Weary, and I'm a practicing family physician in Dahlonega. I'm a past president of the Georgia Academy of Family Physicians, and I currently serve as the chairman of the GAFP's Legislative Committee. The Academy is the only organization solely dedicated to primary care, and we have over 2,600 members, including family physicians, family medicine residents, and medical students. As you're probably aware, family physicians are experts in prevention and treatment of most acute illnesses and management of chronic medical conditions. I know I need to be brief, so I'll be very succinct as I bring my message to you. I've got 3 points that I'd like to make about the budget. The first point is related to the 1% cut. 2011 marks 10 straight years that physicians who treat Medicaid patients have not received an increase in rates. Nothing in our practice costs less or even the same as it did 10 years ago. We are the only provider group in Medicaid that has not received an increase over the last 10 years. As the chart that we've provided for you that looks something like that illustrates, the gap in our Medicaid payment versus Medicare now is a 43% gap. We ask that you restore our cut, which is a 2.4% million in state funds. Please help me by restoring the cut so that I can continue to make the case to my colleagues that brighter days are ahead and for them to continue to take Medicaid patients, both children and adults who qualify for Medicaid benefits. As you know, when there aren't enough adequate physicians to take care of the Medicaid population, they end up in the emergency room. The recent growth in the use of emergency departments is costly, undesirable, and unnecessary. This trend is partly due to a growing proportion of people who lack a usual source of care. This group is increasingly likely to rely on emergency rooms for their health care compared with those who have a usual source of care. This isn't good medicine, it isn't good business, nor is it good policy. Our second point is related to restoring the capitation rates for family medicine residency programs, which you will find in the DCH budget under the Georgia Board for Physician Workforce. It can be found on the tracking sheet of 17.22.1 with a recommended cut of $337,000. The federal match on this funding is $1.60 for every dollar of state monies. Residency capitations rate assist our 10 family medicine residency programs with support for our family medicine residents, which can include benefits and salaries. Help us to keep our residency programs competitive with other states so that we can keep more Georgia medical students in Georgia when they choose a primary care residency program. The residency programs are held accountable for this money, and if they fall below 50% of their graduates staying in a rolling 3-year basis, they have to return that money to the state. As you heard earlier this week, last year only 8 Georgia medical school graduates selected a family medicine residency program in Georgia out of a potential 63 slots. The rate of Georgia medical school graduates entering family medicine has significantly declined from an average of 20% in 1999 to an average of 4% in 2009. Family medicine cannot sustain itself as a specialty if aggressive support is not given to the specialty, especially in Georgia. Which brings me to my last point. You need to help me replace myself. I graduated from the Medical College of Georgia in Augusta, and I won't tell you what year. and then completed my family medicine residency training at the Medical Center in Central Georgia. I've raised my family and served my community in North Georgia for over 30 years. Taxpayers who helped support my training, I believe, have gotten their money's worth. But we are literally a dying breed. In 2006 report produced by the Georgia Board, it noted that 31% of Georgia's family physicians are 55 and older. Please consider supporting a state tax credit for primary care physicians to precept and mentor Georgia medical students to encourage their interest in choosing family medicine and also maintaining their connection in remaining in Georgia for their post-medical school training. We are sensitive to the tough times that we all are in, and also aware of the added pressures of current state revenue situation. A continuous flat line in payment by Medicaid, as shown in this graph, makes additional cuts, even during downturns in the state's economy, even more difficult to bear. I appreciate the time today, and I appreciate y'all's service to folks in Georgia, and I would be happy to answer any questions.
Thank you for your presentation, and we appreciate the good work you and your fellow physicians do with us. Next, we're going to have Dr. Fincher, and then Dr. Fincher will be followed by Amy Fantich, I believe is the way we pronounce it.
Mr. Chairman and members of the committee, my name is Dr. Jacqueline Fincher. I am the governor-elect for the American College of Physicians and also serve on the Council on Legislation for the Medical Association of Georgia. I am a full-time internal medicine physician in private practice in Thompson in rural East Georgia. On behalf of the medical students, residents, and members of the American College of Physicians, I thank you for this opportunity to speak to you today. I stand before this committee as a physician and as a small business owner. That's right, I sign the front of the checks, not just the back of them. Like other small businesses in Georgia, I am struggling to maintain a profitable primary care practice in an extremely difficult business environment. I am one of 8 primary care physicians in our small town. All of us see Medicaid patients, mostly at a loss already, as they require so much time and effort with tremendous social work needs that greatly impact their medical care. Now, the proposed budget before you is a 1% cut in Medicaid physician payment rates. However, that does not tell the entire story, as Dr. Weary alluded to. As we look at the chart provided in your folder, which is this one, it demonstrates the unsustainable financial practice of medicine, particularly in primary care. The chart does speak for itself. The physician Medicaid rates have remained stagnant since they were actually cut in 2004, as you can see on the bottom red line over there. The net effect of an additional 1% cut proposed in the state fiscal year 2012 budget actually results in a 36% cut since fiscal year 2003, and its adjustment for inflation during that time. If it had kept up with inflation, it would have followed that blue line. Now, when compared to the actual Medicare rate, not that that's any great rate either, by the way, for the most commonly used evaluation and management CPT code that is the bread and butter of primary care practice, the rate is actually 43% lower than the Medicare rate. Now, that 1% cut may seem innocuous. However, when considered in the context to either medical inflation or actual Medicare rates, the cut is profound. One final thought. Georgia is plagued with a shortage of primary care physicians, internists, pediatricians, and family physicians. And the state Medicaid rolls are expected to increase by over 600,000 patients through the Health Care Reform Act. Now, given the current state of payment cuts and the expected increase in the number of Medicaid patients, all Georgia citizens will face serious access problems to quality primary care. As a small business owner and a practicing physician, this sober reality gives me great pause about my own continued ability to keep my practice open and provide quality care to my patients in McDuffie County. There are currently 26 counties in Georgia that do not have an internal medicine physician. It is important, and I will echo Dr. Weary, there's nobody coming behind me either. I've been in practice 22 years in Thompson, and we have not seen a new primary care physician in our town in over 10 years. Thank you again for this opportunity, and we urge your favorable consideration of offsetting any proposed cuts to the physician Medicaid payment. Thank you.
Dr. Finch, thank you very much. Next on our list, Amy Fine-Touch will be followed by Mary Frances Williams.
Thank you. Good afternoon. My name is Amy Fine-Touch, and I'm a member of the board of the Georgia Breast Cancer Coalition. Thank you for allowing us to speak with you today about the fiscal year 2012 budget. Sorry, I'm a little short. GBCC is a grassroots advocacy and education organization founded by breast cancer survivors that focuses the attention of Georgia citizens on the epidemic proportions of breast cancer. We advocate for early detection, lifestyle improvements, treatment, and research. We are here today out of particular concern for two proposed cuts in the Department of Community Health budget. The nearly $2.5 million cut in grant and aid to the county health departments and the 1% reduction in the Medicaid physician fees. First, regarding the proposed health budget grant and aid cut, we'd like to thank you for voting to restore a similar proposed cut in fiscal year 2011 amended budget. This was an important step, and we urge you to take the same action in 2012. As you know, recent years of budget stress have meant repeated reductions in formula grant and aid to the point of services being severely affected. Health departments in the Breast Test and More program are the front line for breast cancer screenings for Georgia women and the entry point for the Medicaid breast and cervical cancer program for women found to have cancer and related conditions. Grant and aid funds help pay for the nurses needed to provide the screenings for thousands of women. When health departments are understaffed, they cannot meet the need adequately. A DCH report shows that the public health nurse workforce has fallen from 1,816 nurses in 2002 to 1,424 nurses in 2010, largely because of low pay. At the same time, Georgia's population has grown significantly, and the loss of jobs and health insurance has forced even more women to seek cancer screenings through their health departments. Recent calls to health departments have found that there are large lengthy waits for appointments for screenings and further delays for mammograms on referral. Please restore the funding for the health department grant and aid in the fiscal year 2012. Women's health and lives are at stake, and early detection and treatment are necessary, or the cost to Georgia will be great. On our second and related concern about the proposed 1% cut in Medicaid physician fees, several thousand women discovered to have cancer through the Breast Test and More program will receive their treatment through a special Medicaid breast and cervical cancer program. We are very concerned that the access to life-saving care will erode, even more as further result of already low physician fees. It is our understanding that Georgia's Medicaid fees are more than 40% below the rates paid by Medicare. We hope that you will prevent the proposed 1% cut in the fiscal year 2012 and that you will soon take steps to scale these fees back to reasonable levels. As we make these requests, we are very much aware of the Georgia's current financial straits. We know that our state's tax structure is outdated and that in its current form it will not generate sufficient revenues to meet current or future needs. We ask that you address this problem now by enacting legislation to reform the tax structure and that you raise the tax on cigarettes by $1 per pack. We have already gone too far in attempting to resolve budget issues through cuts in services alone. We need a balanced plan that includes sufficient revenues to help create a prosperous and healthy future for our state and for our people. Thank you for all the work that you do and for the opportunity to express our comments and suggestions on the fiscal year 2012 budget.
Amy, thank you very much.
Thank you.
Appreciate you being here. Mary Frances Williams will be followed by Gina Agnew.
Thank you very much for this opportunity to speak to you. And I'm Mary Frances Williams, and I'm speaking on behalf of Healthy Mothers, Healthy Babies Coalition of Georgia. The Healthy Mothers, Healthy Babies Coalition of Georgia was conceived in 1973 to improve access to prenatal and preventive health care for low-income women and children in Georgia. And since 1984, we've been operating a statewide telephone hotline for pregnant women who are having difficulty finding affordable prenatal care. It's expanded a lot, and now serves a much broader population of low-income women, children, and men seeking health care and public health services in Georgia, and last year assisted more than 27,000 individuals. But the real reason I'm here to talk to you today is about the Children's First program. A proposed cut in the fiscal year 2012 budget threatens this statewide program that identifies and screens children ages birth to 5 that are at risk for poor health and developmental outcomes, refers and links them to appropriate services, and monitors their health status. And it's kind of confusing in the budget, and I don't have a line item for you, but in the DCH budget, a cut has been proposed in infant and child essential health treatment services program area, and the cut is a $2.9+ million in state funds, and the line item states reflect savings from the discontinuation of the Babies Born Healthy program. I know it's confusing. But the Babies Born Healthy program was administratively closed by the Department of Community Health in June 2010, and the funds were shifted to Children's First. Children's First had lost funding because of the loss of a Medicaid match, and they were trying to find funds, and they used the Babies Born Healthy money to go to Children's First. So the proposed cut to Babies Born Healthy is actually, and is in fact a cut to Children First. Children First is a statewide universal screening program. It's the single point of entry into public health services for children birth to 5 at risk for poor health and developmental outcomes. The primary goals of the program are to identify all at-risk children ages birth to 5, link them and their families to appropriate public health and community services, and to link at-risk children to a primary care provider. And the truth of the matter is that Georgia's public health infrastructure for young children would cease to exist without this program. There are Children First coordinators in each of the 18 public health districts, and 15 of these 18 coordinators are nurses. Other staff that are in the program, and these are spread all over the state, they're in every health district, they serve every single county, are universal newborn hearing screening coordinators, additional nurses who are not coordinators, developmental specialists, dietitians, and professional health care workers. Services are available in all county health departments at no cost to families. And I'm not going to read the statistics to you, but I have some statistics about the number of folks who were served in FY 2010. A cut of this magnitude will make it impossible for the program to continue to operate as a statewide program. Georgia will lose its public health infrastructure to screen infants and young children at risk and provide referrals to necessary intervention. And for example, many infants and young children with hearing loss will not receive intervention soon enough to prevent speech and language delays. Infants and toddlers with disabilities will have a more difficult time connecting with early intervention services, which are so crucial in bringing those children up to speed with other children. Families with infants and young children with medical and socio-environmental issues will not receive prevention-based health education on programs and services available to support their children, and private physicians will not have a single point of contact to connect their patients to public health programs and services. And also, fewer children would be enrolled in affordable health insurance programs. I'd also like to comment that Children's First also fulfills 2 federal mandates for Georgia, one for developmental screening for the Babies Can't Wait program, and also it fulfills the federal CAPTA, Child Abuse and Prevention Treatment Act requirements for children birth to 3. Again, I've already said it, but Georgia's public health infrastructure for young children would literally cease to exist without this program, so I hope you will restore the funds.
Mary Frances, thank you very much. Gina is going to be next, and after that, Andrina Patton. Thank you.
Hi, I'm Gina Agnew. I am the Executive Director of the Northwest Georgia Regional Cancer Coalition. That's a mouthful. and also the president of the Council of Regional Cancer Coalitions of Georgia. With me today, I also have my peers from the East Georgia, West Central, and Central Georgia Cancer Coalition, so if there are any questions, you can ask them. I would like to make you aware that each of the regional cancer coalitions participates in a variety of positions on the Georgia Comprehensive Cancer Control Plan, the steering and development committees, and the implementation. Currently, it is unfunded, yet each of us strives in the development of our individual programs to include the objectives, strategies, and metrics of the plan. We are the first-line deliverers of that plan on a community basis. One of the biggest strengths the RCCs bring to the table is our ability to build relationships among disparate entities. Each of our coalitions contains a wide variety of partners, competing hospitals, public health, community organizations, volunteers, survivors. We have the ability to bring these groups together to provide services that are not possible without our participation. We have the ability to respond quickly when approached from other organizations and pull together collective resources. For example, 3 years ago, the Council was approached by Dr. Joe Lipscomb, Professor of Health Policy and Management at Rollins School of Public Health, Emory University, for assistance with a rapid quality reporting system. We were able to pull together 8 alpha sites throughout the state of Georgia and 30 beta sites for that program. It was a project of the American College of Surgeons Commission on Cancer and was designed to provide feedback in near real time on 6 breast and colorectal cancer measures. We have 2 items that we would like to address today. The first is the 8% budget cut to the regional cancer coalitions in 2012. Now, we're not going to whine about that too much because we are still in the budget, and we're very excited to still be there, very grateful. But we would like for you to be aware of what these budget cuts will mean on a local level and hope that you would consider cutting a smaller percentage of our relatively small budgets. You have 2 handouts in front of you. The first one is a collective summary of programs and services outcomes and return on investment for fiscal year 2010. I think it's important to note that the number of screenings provided was 5,767 and that 623 abnormalities were found. Of those, 75 were cancer. We concentrate on breast, prostate, colorectal cancer screenings. A late-stage cancer diagnosis means treatment costs of approximately $250,000 per patient and rarely more than 3 months extension on life. If cancers are found in the early stages, or in the case of colonoscopies, precancerous polyps, they can be treated and or removed at an expense of less than $3,000 with vastly longer lifespans. The key to getting patients in for screenings is education, and you can see that our collective outreach efforts have impacted over 111,000 individuals. We have also assisted nearly 4,000 patients through our patient navigator programs. I believe you can see the bang for your buck throughout that report, and I won't review the entire report with you. The second handout shows the impact that an 8% budget cut will have on our efforts. 80 colonoscopies cannot be performed on underserved patients, missing an estimated 4 to 6 cancer diagnoses and 50 precancerous polyps not removed, which translates into higher long-term cost for later stage treatment, often at the cost of the state. 12 smoking and tobacco cessation classes cannot be conducted. That's approximately 300 patients that will continue smoking and chewing tobacco. And/or 6 school systems will not receive tobacco prevention education for K through 12, approximately 21,000 students. 10 screening promotion events would not be held, affecting approximately 2,000 individuals. 5 part-time community health navigator, cancer services navigator positions will be eliminated, impacting an average of 2,500 patients, and 4 community health advisor worker positions will be eliminated, affecting approximately 1,500 individuals who will not receive cancer education. A lesser cut would still have a negative impact on the delivery of our screenings, education, and navigation efforts, but a much smaller negative impact. The second issue we would like to bring to your attention, and I'm hurrying, will relate to our funding host. There's been some discussion about moving us from the GCC to the DCH. A case can be made for either one, and we would just like to state that we will work very closely with either one that we are assigned to, and we want to be of the greatest possible value to the state. My mother died of colorectal cancer. It's 19 years ago. She was 52 years old when she was diagnosed. If she had been educated to have a colonoscopy at 50, those precancerous polyps would have been removed and I would still have my mother. So as you can see, screening and education are both extremely important. Thank you. Any questions?
And thank you very much. Andrina Patton is next. That's number 11. Yeah, let's try that.
Can you hear me into it? Okay. My name is Andrina Patton, and I'm here to talk to you guys, and thank you for the opportunity, about unlocking the waiting list, particularly the independent care waiver program. But before I get into that, I kind of want to talk to you about an individual. Her name is Brittany Cox. She is 26 years old and has a 7-year-old. In October of last year, she was shot 5 times and sustained a spinal cord injury. Well, after leaving the hospital, she had to go live with her mom. But she's a single parent, and now her mom is providing care for him as well as providing all of her care. She relies on her mom to get her out of bed, to bathe her, to help her to go to the restroom, to help her transfer in and out of the chair, to help her do everything. Her mom worked full-time prior to Brittany's accident. She had to decrease her days to 2 days because she's the sole caregiver of Brittany and her son. She ended up having to provide housing that was accessible, moving out of a house that she had lived in for 20 years, all because Brittany couldn't live there. They had to find all this equipment so that Brittany would be able to stay in her home and have her son in the community where they wanted to live. And Brittany's mom was so upset and didn't know what to do because she wasn't going to put her daughter in a nursing home so that her son would never see her or see her mother, his mom in a nursing home. So Brittany applied for the independent care waiver program. And since fiscal year 2009, there have been no slots at all. So what Brittany's really applied for is a waiting list to sit there and wait. And she has no idea when she's going to get approved because typically we haven't been putting slots in since fiscal year 09. Well, I've been utilizing the independent care waiver for 10 years. And this is Jennifer behind me. She's my attendant. Without her today, I wouldn't have gotten out of bed and I wouldn't be speaking to you guys today. I wouldn't have gotten to go to college. Wouldn't have gotten a master's. I wouldn't have learned how to drive. I wouldn't have a job. And I wouldn't be living in my own apartment and having people come in and help me and not having to always rely on my mom. When I told Brittany what I did, she had so much hope. She thought that, wow, this program is going to allow me to do all of this. Well, when I told her the situation and the waiting list, she was optimistic and thinking, oh, well, maybe if we talk to the legislators that we can have some slots put in. However, there's 163 people right now waiting. There are no slots. There haven't been slots since 09. There were no slots in 10, no slots in 11, and there's nothing for 2012. People with disabilities need to be in their own homes and participating in the community just like everybody else. Imagine not being able to get out of your bed until somebody comes and helps you get out. Imagine not being able to go to the grocery store unless somebody is with you. Those services are so vital. Nobody wants to live in a nursing home. Everybody wants to live in their own home. And that's why I implore you to give those 163 people and everyone else in the community hope that they will be able to do those things in their own home and not in a nursing home. So I ask that you please consider 163 slots under the Independent Care Waiver Program. And thank you for your time.
And thank you for making the effort to be here today and telling us that. Thank you very much. Next, Pat Noby, and Pat will be followed by Dr. Cindy Mercer.
Good afternoon, Mr. Chairman. Thank you for the opportunity. I'm with the Georgia Council on Developmental Disabilities. We had Disability Day at the Capitol today. We had a couple thousand people here to support some of the issues that we're working on. I could speak to several things in the DCH budget. One is what you just heard from Andrina Payton, the 163 services for people that need independent care waiver program services. I could support what Mary Frances said about the Children's First money, because children with developmental disabilities, that's the way we identify them and get them into early intervention services. And the money that we spend on children between birth to 3 saves us a lot of money in the long run with special education and independent living support later on. The other thing I wanted to speak to you about is the dental services. Prior to this budget being released, I know that the Department of Behavioral Health and Developmental Disabilities was starting to work up some numbers and proposals for actually adding to the dental services that people with developmental disabilities would be receiving. Adults with DD and physical disabilities who are on Medicaid only get extractions in emergency situations. And, you know, this may not be a technical legal violation of their civil rights, but imagine being a person in your 30s or 40s going through the rest of your life without teeth. We actually have a mandate now from the Department of Justice to move a number of individuals out of state hospitals over the next 5 years. And most of those folks have not had good routine preventative dental care. And now they're going to go into the community for the first time in their lives, some of them, and be getting up every day and facing 3 meals a day of pureed food because they don't have any way to masticate the food. There is actually a young woman in Rome who, for the first time in 15 years, is going to be moving into the community. She's 48 years old, and she is going to have all her teeth pulled in a week or two because she didn't have the dental services that she needed. Just a little personal story. DD councils across the country share a lot of information. A couple weeks ago, I got a booklet from the Maryland DD Council that it was a picture book of adults that they had moved out of institutions into the community. And they were nice, you know, full-size pictures of these individuals with their caregivers that they're living with now in the community, in their own homes. And I'm paging through the book, and something struck me, and I handed it to Eric Jacobson, my boss, and I said, what do you notice in these pictures? And he said, well, you know, they're nice pictures with their caregivers or whatever. He said, why? And I said, they don't have any teeth. None of the adults in this picture book had teeth. Now, it's not only about health. It is about health. It is about their ability to eat and enjoy food. It is about their ability to go to restaurants and do things that they've never been able to do. It's also about social stigma, because these are individuals that we're trying to incorporate in the community and have lives like everyone else, and they're facing those lives not only without teeth, but without the possibility of having dentures or anything that would actually enable them to eat like a typical person. So that's all I wanted to say. I just wanted to share that perspective with you today, and you know, just encourage you to look at not only the emergency dental care, but also expanded dental care for people with DD. It's been a really long time since we've had, you know, that kind of dental care for people with developmental disabilities. Thank you.
Thank you very much, Pat. Dr. Cindy Mercer, and Dr. Mercer will be followed by Elizabeth Apley.
Thank you, Chairman. Thank you, committee. We appreciate your time. I'm Dr. Cindy Mercer. I'm from Athens, Georgia. I'm in private practice. I'm president of the OB/GYN Society, and I'm speaking on behalf of all the obstetricians and gynecologists in the state of Georgia today. We appreciate the great financial burden that you find yourselves in trying to work out the budget deficit, and we feel like we're a little bit in similar shoes providing Medicaid obstetrical care throughout the state. We feel like this is an economic model that can't be supported, and I have grave concerns about the future of obstetrical care in the state of Georgia. Last year there were 140,000 births in the state of Georgia. 59%, or that's 84,000 deliveries, were covered by Medicaid reimbursement. Now in rural Georgia, 80% of all deliveries are covered by Medicaid. So in our non-metro areas and in some of our underserved areas, 80% of an obstetrician's practice is reimbursed by Medicaid funds. For the past 10 years, obstetricians have been paid at the same OB rate. So the graphs that you looked at earlier also apply to the obstetricians. With the rising cost of living, with malpractice cost, With rising administrative costs in the office, obstetricians will not be able to keep their offices open. When you have an 80% dense Medicaid population practice, there's no other area in your practice to be able to support that financial viability. We have seen practices close throughout the state this year. Take, for instance, Dr. Joel Higgins, who was our 2009 past president. He was born and raised in Waycross, Georgia. He was educated and trained in the state of Georgia. He went back to his hometown of Waycross to take care of his the community in which he grew up. And now, after 10 years of practice and no increase in Medicaid rate and an 85% dense Medicaid population, rising cost, he has been forced to leave the state. So he's gone to a state that is more favorable for obstetrical practice. Another obstetrician in Waycross has also left. Now, when a doctor leaves a community or a doctor leaves a state, we certainly have access to care issues, especially, but we also see the loss of important economic revenues that a physician practice provides for that community. We've seen other obstetricians leave the state this year. 3 obstetricians have left LaGrange that provide a very high volume obstetrical practice. 1 has left Americus. 1 has left Statesboro. There's only 1 obstetrician in Moultrie. Now, these are not small towns across the state of Georgia. There are 69 counties in the state of Georgia that do not have an obstetrician, and these numbers will only increase with our Medicaid deficits. These are not doctors that are ready for retirement. These are 40-year-old doctors to 50-year-old doctors in the prime of their career, and we cannot recruit doctors to South Georgia or to actually Georgia in general because of these rates. There are other states that are more popular to practice OB in. When we see these loss of physicians and we have the inability to create, we see that we have increased morbidity, increased prematurity, increased high risk, and in the end, this costs the state more money. And because of rising costs, a 1% cut will make obstetricians leave the state, and it will cause metro doctors to stop taking Medicaids. This loss of care will be an access issue. Now, remember last year there were 84,000 deliveries in Georgia that were Medicaid paid for. Obstetrics is a 24-hour, 7-day-a-week job to provide emergency care. This is not a service that can be provided by an allied health care provider or by a physician extender, so we have to protect our obstetricians. We realize that funds are limited. We do support the tobacco tax increase. We think it's a win-win for the health care of Georgia. We're here as obstetricians to provide quality care to the state of Georgia, and we'd like to be able to continue that, and we appreciate your time and listening to us. Thank you.
Dr. Mercer, thank you very much. Elizabeth Appley, and then Joanne Yon.
Mr. Chairman, members of the committee, my name is Elizabeth Appley, and I'm here this afternoon on behalf of the Georgia Dental Hygienists Association. We are the voice for more than 6,600 dental hygienists who practice across the state. We wanted to raise up to you issues that you just heard from Pat Noby, the DD Council, and in recent weeks, obviously, from the Georgia Dental Association, from Families First, from Georgia 2020 and others, highlighting the importance of restoring funding for dental care in Georgia. As you know, access to dental health care is the #1 unmet health need for adults across the state. We have a 3-part cut that would negatively impact access to critical care, both in terms of the elimination of the emergency extraction for low-income adults under Medicaid, the elimination of the broader but still basic dental care for pregnant women under Medicaid, the cut to the provider fees of 1%, and the cuts to the grant and aids to the public health departments. We know from hearing the committee's questions to the Commissioner last week that you understand these issues, and so we're just trying to lend our support and some added facts to demonstrate that these proposals are not only wrong in terms of good social and health policy, but they won't have the effect of saving the state money. This won't benefit the taxpayers in any way, because we know that there's a critical link between dental health and good overall health. We know that when you have the Department of Community Health has made the decision over time to provide access, for example, to pregnant women, because there is a link between the importance of good oral health care in addressing periodontal disease and preventing preterm birth, the single largest cause of death in newborns. We now have over 500,000 preterm babies born in this country at a cost to our health care system in excess of $26 billion. We know that access to simple preventive health care services to women to reduce periodontal disease during pregnancy will have a beneficial impact on birth outcomes. We also know that the vast majority of states provide access to dental services under Medicaid, including all of our neighbors in the South. In fact, most states provide more extensive access to dental care than Georgia does. Finally, the reality is that when you eliminate the access to the extractions, that you are not sending that problem away. It will not resolve on its own. You have a person with an abscess, they cannot work, they can't go to school, they will end up in the emergency room with an extraction, with an emergency room visit that will cost 6 or 7 times what it would have cost to provide it through the CMO under Medicaid. So we thank the committee for its attention on this issue. We want to support you and appreciate your efforts to restore these 3 aspects of dental health care.
Elizabeth, thank you very much.
Thank you.
Joanne Yon, and next will be Rick Ward.
Mr. Chair, members of the committee, thank you very much for this opportunity to provide comment. My name is Joanne Yoon, and I manage the Child Health Policy Agenda with Voices for Georgia's Children. We are a policy and advocacy organization speaking up for the well-being of children within the state, and it's from the child health perspective that we wish to share some comments with regard to the 2012 budget. To begin, there are certain aspects of the budget for which we'd like to commend leaders within the governor's office and also within the agency in moving toward implementing more family-friendly processes, at the same time maximizing the opportunity to receive federal dollars, whether through a bonus or through a generous federal match. The first of these instances is with regard to the $10 million that's been allocated within the 2012 budget to work toward improvements within the Medicaid enrollment system. This is a timely opportunity since right now the federal government will offer a 90-10 match on every state dollar that's invested. And this is a good opportunity for us to make sure that consumers will benefit from the improvements as much as possible. The second is with regard to the $6 million that is anticipated funds to be received from the federal government through the 2009 Federal Children's Health Insurance Program Reauthorization Act, or CHIPRA legislation. It's our understanding that Georgia currently does not stand to qualify for the bonuses, but that we do know that the agency is working tirelessly in order to implement changes to streamline enrollment practices before the deadline of April 1 in order to receive the funds before the end of this calendar year. At the same time that the committee and other leaders are looking to streamline practices and improve continuity of care, the two recommendations that we'd like to make is to look toward 12-month certification process for those enrolled in the Medicaid program, which has been discussed and addressed by this committee prior. The second recommendation we'd like to make is to look toward 12-month continuous coverage, since we know that the better the continuity of care for children, the better the health outcomes. At the same time, there are aspects within the budget that do cause us concern in terms of how it may negatively impact access to care, critical health care needs for the most vulnerable of Georgians. This first is with regard to the proposed 1% provider reimbursement cut. While at the same time we do recognize and appreciate that this is significantly lower than what had been proposed prior, it is still an area of concern. The second area is with regard to implementation of co-pays for children enrolled in the Peach Care for Kids program who are over the age of 6. Not only are we concerned with the access, but we're also concerned with a proposed or a potential change in utilization rates, and that children may not be as likely to go seek primary care provision, but instead this may lead to increased hospital in-stays as well as an increase in ER utilization. The last thing that I would like to address is our concern, as has been mentioned before, with regard to the $2.9 million proposed cut from the Children First program. And all of you have heard before about a lot of the services that are provided for newborns and the youngest children who are born in the state of Georgia. As has been mentioned before, it was our understanding in meetings that were held between community advocates and leaders within the Division of Public Health that upon termination of the Babies Born Healthy program, the $2.9 million would instead be transferred in order to bolster the Children First program. In looking at the current budget documents, however, we see that the $2.9 million coming about from the termination of the Babies Born Healthy program has instead been cut out of the budget rather than transferred to Children First. To sustain a cut of this magnitude would severely undercut the ability of Children First in order to screen, coordinate care for healthy development for children. And so for these reasons, we would ask for you to take another look at that particular part of the budget. Members, again, thank you so much for this opportunity. We appreciate your responsiveness to our concerns. Thank you.
Sharon, thank you very much. Rick Ward.
I'm obviously not Rick Ward. I'm Catherine Cheek, and I'm speaking on Rick Ward's behalf. I'm actually a pediatrician. I practice in private practice in Columbus for the last 25 years. Rick is our executive director, and I am the president of the Georgia chapter of the American Academy of Pediatrics. Our chapter represents nearly 1,700 primary care pediatricians and pediatric subspecialists in the state that provide for Georgia's children. I would like to address three items in the budget which you've all heard about already. Those are the provider cuts, the co-pays in the Peach Care program, and then also the cut to Children's First program. Many of you know, I'm sure, that in terms of the number of patients it serves, Medicaid is essentially a children's program. Children make up 2/3 of the patients in this program, but actually only consume 1/3 of the cost, whereas the adult patients make up 1/3 of the patients but consume 2/3 of the cost. So you have to remember, whenever you cut Medicaid, you're strongly impacting the health care of children in the state. Pediatricians provide the vast majority of care to the children in the state, and therefore they are highly impacted by Medicaid reimbursement levels. 60% of our members across the state say that Medicaid represents greater than 40% of their total patient volume. I appreciate the governor's efforts in these very tough economic times to suggest reductions to us that are less than what the department suggested in the fall. But having acknowledged that, I must tell you that Medicaid reimbursement in our pediatric population is on an unsustainable path. Medicaid rates, you've heard, have not been raised for the last 10 years. The rates are only 70% of the Medicare rates. I fear that this may put many of our practices in. We already see practices closing their doors to Medicaid patients just because they can no longer proceed forward with their capacity to see these patients. If there's any possible way to avert this cut, I and my fellow pediatricians would hope this committee would consider that. However, if you decide that this cut has to be sustained, we would ask this committee, we know your appropriations, but you have to do whatever you can to help ease the administrative burden that is placed on our practices every day from the Medicaid program and from the CMOs in our state. I could spend the rest of the afternoon discussing the administrative burden to our practices, but I'm sure you don't want me to do that. But suffice it to say that a system that pays low and places unnecessary administrative burdens on us that are more than double than what we see in the private sector is a system that is doomed to fail, affecting both the patients and the providers. Now, moving on to the copays in the Peach Care program, we have concerns about these. Many patients and parents will not be able to pay them, so when a sick child arrives at our doorstep with 104 fever, or a child that's vomiting, or a mother that's just concerned and frantic that she's worried about her child, that child is going to be seen. That's just what pediatricians do, and that's what most other doctors do. So essentially the copay will go uncollected, simply be absorbed by the practice as a loss, and is essentially another cut in our reimbursement. If you decide that the copays must be implemented, please make them whole dollar amounts. We don't want to be making change in the office. We have to have some relief to the administrative burdens in our system. We also ask that you consider other ways to perhaps make up this revenue that you anticipate to gain through the copays. Additionally, I'd like to commend to you the Children's First program, which you've already heard much about. The $2.9 million cut is just devastating to this program. It is one of the most important public health programs that we as providers work through and serve our patients every day. It is a major source in identifying infants and young children with disabilities. It links our newborn screening programs, and it provides connections to services to children with complex medical problems so that they may move forward to be successful Georgia participants in the future. I suspect that each of you know of a child that has a special need. You know that it's devastating to the family. You know that only programs like this can help these families get through this and help these children fulfill their full potential. I would appreciate anything you can do to restore some of this funding in the budget. In closing, our Medicaid system provides health care to our state's most vulnerable citizens. It must be one that provides adequate resources to the physician that provides those services. As pediatricians, we truly feel that our state's most valuable natural resource is its children. We want to work with you any way we can to help these children move forward in their future to be healthy. Thank you.
Chief, thank you for being with us today. We appreciate you coming. Next up, Skin Edge, and then Sam Grossman.
Thank you, Mr. Chairman, members of the committee. Good afternoon. My name is Skin Edge. I am representing a community coalition for effective sustainable services, otherwise known as the Access Healthcare Coalition. The Access Coalition is a diverse coalition that consists of groups such as the Georgia Hospital Association, the Georgia Chamber of Commerce, the Metro Atlanta Chamber of Commerce, the Association of County Commissioners of Georgia, and several physician trade groups representing family practitioners, pediatricians, and OBGYNs. The coalition was formed in 2007 in an effort to strengthen access to care for all Georgians by encouraging the state to fulfill its commitment to adequately pay for health care services to the state's Medicaid population. As we all know, adequate funding for Medicaid has become, during these economic times, one of the biggest challenges facing state governments, including Georgia. That is why the Access Coalition is extremely thankful to Governor Deal for his recent state budget proposal, which spared the Georgia healthcare community of the large Medicaid rate cuts that had been discussed by the Department of Community Health last fall. It is clear that the governor understands how fragile our state's healthcare delivery system is right now. With that said, the governor's budget does call for some smaller cuts to Medicaid that, when added to all the previous cuts over the past several years, threaten to make a bad situation even worse. The proposed 1% Medicaid cut is a real concern to the Georgia physician community. Presently, Georgia physicians are paid about 43% less for services to Medicaid recipients than they are for federal Medicare recipients. The end result of these continued cuts is reduced access to care for every Georgian. From Dalton to Valdosta, from LaGrange to Savannah, Georgia physicians, frustrated by declining Medicaid payments, are refusing to treat Medicaid patients or are making other difficult career decisions such as reducing services, retiring early, or leaving the state altogether, as you've heard earlier today. In rural areas throughout our state where roughly 60% of all births are Medicaid, the number of obstetricians who can deliver these babies is dwindling to crisis levels. As has been stated, Waycross recently lost 2 of its OBs, and it has only 3 now to deliver children. I don't need to tell you how damaging this trend is to all Georgians. As everyone here knows, we are in the midst of the most challenging economic times the state has ever seen, and everyone is being asked to sacrifice to help balance the budget. Health care providers understand that and have been on the front lines of budget cuts for several years now. The problem now is there is simply nowhere else to cut. Many Georgia health care providers, especially those in the physician community, have reached their breaking point. As you make these difficult budgetary decisions, we ask that you consider the impact of any further cuts on our state's health care delivery system. More cuts equal fewer physicians to care for Georgia's growing population and less access to health care services for all Georgians. Mr. Chairman, members of the committee, as has been stated earlier, to restore this 1% cut for primary care physicians in the state will take about $2.4 million. We realize that these are very difficult budget times, and even in a billion-plus dollar budget, is multi-billion-dollar-plus budgets we have in the state of Georgia, $2.4 million is a lot of money. However, we would implore you to try to look and see if there are ways to access that money, to restore the cut. Perhaps Chairman Chanel, and if they work their magic with the tax council's report, there'll be some dollars there. But we'd ask you to take a look at that and perhaps some other ideas that we'll be talking with you about as we move through this process in the coming days and weeks, because it really is, as you've heard over and over today, a crisis here in the state of Georgia. Thank you very much.
Again, thank you. Appreciate you being here with us. Sam Grossman is next, and then Marilyn Kowalski.
Mr. Chairman, I'm actually not Sam Grossman, but I do work with Sam Grossman. My name is Dr. Mike Dwyer. I am a neonatologist, practicing neonatologist here in the Atlanta area. I'm part of a larger group of physicians throughout Georgia called Pediatrics Medical Group. I represent about 160 some odd physicians and advanced practitioners who provide neonatal care to some of our smallest citizens in the state of Georgia. In addition, we have another arm of our company called American Anesthesiologists of Georgia, who provide anesthesia services at a couple of the hospitals that I work at, namely Piedmont Hospital and Piedmont Fayette Hospital. Together, we provide services through a lot of the metro Atlanta area hospitals here in Atlanta, as well as in Macon and Augusta, Savannah, Fort Oglethorpe, and several other places throughout the state. I appreciate the time to come here and represent these some 250 or so advanced practitioners and physicians here in the state, so that you can hear our thoughts about why we oppose the current proposed 1% reduction in Medicaid. I and my partners collectively constitute the largest Medicaid providers for pediatric subspecialty care in Georgia. We provide services in hospitals where more than about 1/3 of all the births in Georgia occur. As hospital-based physicians, we are extremely dependent on the Medicaid population in this state. Throughout the state, our patient population averages about 55% Medicaid, but there are some of our practices that are 80, 90, even as much as 100% dependent on Medicaid. Obviously, any changes in those types of reimbursement have profound impacts on our practices. Our hospital-based services, such as admission to an NICU, are never qualified by the ability of our patients to pay. Anyone that shows up in our intensive care units, regardless of whether they are Medicaid or covered by any other type of insurance or not covered by insurance, they receive the same care that everyone else receives. We are proud of this commitment, and we oppose any effort or any initiative that would negatively impact access to care. Because of our strong commitment to the smallest and newest citizens of Georgia, I'm here not to ask for better funding for our care, although as we've heard today, that would certainly be an interesting discussion and a worthwhile discussion to have. But we're here only to plead that you not take more money away from us. We've already seen testimony today that we've had essentially what amounts to a cut because of the lack of increase in funding, the resulting inflation, resulting in less real dollars for us at our practice. And that's becoming a more and more significant issue for us to deal with. And I'd like to talk about just a couple of areas where it affects us significantly. One of those is in our ability to recruit new physicians to Georgia. We've already heard about other physicians leaving Georgia. This is sort of the flip side of this coin. Without adequate reimbursement levels, I simply can't offer the salaries that will entice new physicians to come to this state, or even entice physicians that are already in this state to remain in this state. The level of reimbursement from Medicaid is directly tied to the level of compensation that I can offer these new physicians, particularly in these practices that are 80 and 90% Medicaid. This concern is recognized by competing states, such as South Carolina, which provides neonatologists and other pediatric subspecialists with an enhanced fee schedule, much less the potentially reduced fee schedule which we Georgia physicians are currently facing. As I mentioned earlier, I'm also here to try to help you and help you serve as a resource for you and come up with new ideas to how we can all deal with the looming healthcare crisis. One of the resources that myself and our company, Pediatrics Medical Group, have created on our own is our own electronic medical record, which we call Baby Steps. It's currently used in about 250 neonatal intensive care units throughout the country. It has about 700,000 patients in it, which represent around 12 million patient days of premature babies throughout the country, a large portion of them here in Georgia. This is a system that we've developed entirely on our own. We don't get any additional reimbursements for this. This is not funded by grant money. These systems and what we're able to do with these systems is purely a function of the reimbursements that we get. So also is purely a function of the Medicaid reimbursement that we get in the various states, including Georgia. We've used this database to enhance our bedside services by evaluating our care and implementing changes that have been measurable and significant benefits to our patients. For instance, as a result of our ability to better chart and follow the care we provide, our system has led directly to a program that has significantly reduced the number of premature infants that suffer the terrible disability of blindness or severe vision impairment. We don't seek extra funding for this. We believe it's part of our mission to simply take better care of our babies. However, we all recognize the financial realities of the services we provide. The computer systems required to capture and maintain this growing database have real dollar costs. Our fear is that due to our patient populations dependent on Medicaid, any reduction in Medicaid reimbursement, even the small 1% that's been proposed, could seriously imperil our ability to continue similar groundbreaking quality initiatives that have a direct patient care effect on all of these infants in this state. As we all struggle with today's healthcare and budgetary crisis, I feel it's imperative that we do not allow these short-term budgetary constraints to limit our ability to create and implement the programs, such as we just described, that will ultimately bring about true healthcare reform and that will provide enhanced outcomes while simultaneously reducing the long-term cost of healthcare. I thank you all for your time. Happy to answer any questions.
Doctor, thank you. We appreciate you being with us today. Next, Marilyn Kowalski, and then Cindy Zeldin would be following up.
Yeah, I wrote to the legislators. I was just upset when they said they needed to cancel the coverage for podiatry, dental, and
would you identify
vision.
yourself?
My name is Marilyn Kowalski.
And do you represent?
No.
Okay, all right.
But I didn't like to hear that the adult Medicaid recipients were going to lose that coverage, and I had the maybe naive suggestion that I wrote to the legislators that maybe they could open this up to the public for their ideas, and my ideas would be that the general public could help out like we do now, helping people with their home heating bills. You add $1 to your bill, maybe add $100, $5, and then professional athletes might be requested to supply great matching funds to that, knowing that that money was going toward that population. Also, I came up with the idea that I suppose many people have the idea. We wish at night that there were cars, vans, buses, whatever, hauling people with alcohol problems off the streets, keeping them from driving their cars. And I assume other people thought that same idea, but to start a company to do that, how could they ever even make ends meet? But if people advocating, to assist funding for things like this that Medicaid just can't afford anymore, would, as I understand it, can't in other states. Also, this would make Georgia kind of distinctive. And if they appeal to, liquor companies to contribute to this type of program, and if the people who were kept from driving their cars, if Georgia was taking this aggressive stance against drunken driving, knew that some of the funds that they paid went toward adult Medicaid recipients, I think that would be a good thing. I have, not to take time, since we're hearing about people in such desperate circumstances, but I do want to remind people when I was here before and they were talking about, of course, thank heaven, that the hospital would still treat, for example, a pregnant woman with an abscess. I'd like to remind people of, who pays when, like, we keep talking about the emergency room has to be used for things it should be not need to be used for, is, as my personal story is the same as so many people in that my husband canceled my health insurance without telling me, and so I got in the situation of the gap in my coverage, pre-existing condition and all that type of thing. And I had the good fortune of actually talking to a lawyer about 6 years ago. And what he told me at that time, I guess most people are aware of, but I was not aware of, and is what they say, what he was saying at that time was that hospitals were so desperate then that they would frequently be suing a divorced couple, one of whom had taken their name off of the house and could no longer afford health insurance, even if the person did not get sick for a whole year later. Now, in my case, thank heaven my kids, are very fortunate, and they don't need the Medicaid and all that type of thing. But on the other hand, they've worked their way through college, and now that their father's deceased, and we're in the same situation where I, signed the quitclaim deed. God forbid if I get sick in the next year before I have Medicare, my daughter, I think, might be sued along with me by a hospital for fraud on account of, I'm supposedly indigent. There's so many people caught in this situation, I wouldn't take your time with this. And I think it does contribute to people using, like they say, abusing the emergency room. When a mother finds out that her kids don't have health insurance anymore, that her husband canceled it. She finds this out a lot of times, and the kids unfortunately find it out too, don't tell her about their symptoms, and then they end up in the emergency room. This is the type of thing I'd like people to think about, and thanks so much for your time.
Thank you, ma'am. Cindy Zeldin, and then Scott Maxwell.
Thank you. Hello, my name is Cindy Zeldin. I'm the Executive Director of Georgians for a Healthy Future, which is a health policy and advocacy organization focusing on issues that impact Georgia's healthcare consumers. On behalf of Georgians for a Healthy Future, thank you for the opportunity to speak with you today about the Department of Community Health budget. Our organization focuses primarily on coverage and access issues, and so I will keep my comments brief, and I will limit them to remarks about the Peach Care and Medicaid programs in particular. These programs are a critical source of health insurance for some of our state's most vulnerable children and families, as you well know, and we're appreciative of the careful consideration that they were given in the proposed budget. We are particularly excited about the investment in the upgrade to the eligibility system that was mentioned earlier, particularly since Georgia will be preparing for an expansion of the Medicaid program under federal law beginning in 2014. We do, however, have some concerns about a few of the proposed changes to the Medicaid and the Peach Care programs that I would like to raise with you. And these changes in particular that would all have the common theme of negatively impacting access to care. The three provisions are the additional co-pays placed on Medicaid and Peach Care patients, the elimination of some of the optional services, vision, dental, and podiatry, and the provider reimbursement rate cuts. Each of these provisions would have a negative impact on access to care. Concern about the co-pays is that they do deter very low-income people from seeking services, which could possibly cause them to seek necessary care in inappropriate settings, and that would incur costs elsewhere in the system. They're also a burden on providers, and that has been addressed by other speakers, and we need to encourage providers to remain a part of the Medicaid system. The elimination of some of the optional services could also result in patients seeking care in an inappropriate setting, leading to worse outcomes and uncompensated care costs elsewhere in the system. Because these proposed changes would negatively impact access to care and ultimately not necessarily save costs in the long run, we urge you to reconsider them. We recognize the difficult financial and fiscal crisis that the state is in and the difficult choices before you, and would also like to encourage you to consider for the legislature as a whole to consider other alternatives such as a tobacco tax, which would have public health benefits as well as generate revenue. Thank you.
Thank you, Cindy, very much. Scott Maxwell, and then Greg Harry.
Most honorable chairman and highly esteemed members of the committee, I'm Scott Maxwell, and I'm with the Georgia Public Health Association. And first, I'd like to say thank you to this committee for restoring the cuts to the general grant and aid that came in the recommended FY11 amended budgets. Those precious dollars will make a huge difference in the lives of Georgia citizens and Georgia's workforce. You know, workforce is a word you may not hear too often when discussing public health. But helping Georgia's workers maintain good health habits and teaching them to be self-responsible for for Disease Management is just one area of public health's influence. By tackling chronic diseases like diabetes and putting people on programs to avoid heart attacks and strokes, public health is an investment not only in people, but in people who make Georgia work. More people able to work, fewer days of work missed because of health reasons, and more productive employees. It all adds up to not only a healthier Georgia, but a state that is more productive and economically strong. But of course, public health does much more than that. And you've heard many of the programs public health supervisors mentioned today already. At the other end of the spectrum, preventing low-weight births and encouraging mothers to delay second births for 2 years also saves the state massive downstream cost. And while saving Medicaid dollars is not a mission of public health, it is certainly a byproduct of its efforts. From inoculations to inspections of swimming pools, restaurants, hotels, and tourist venues, every citizen of Georgia and all of our visitors depend on public health to be able to do its job. And as all of you know, the general grants and aid to counties enable these health problems to be solved at the local level with different emphasis on different problems. What may be true in DeKalb County is not true in Columbia County. Where the emphasis needs to be placed in Gwinnett may not be in Seminole County. And that's one of the beauties of the public health system. So we ask you to please follow suit in the FY12 budget as you did in the 11 and restore the cuts made to the general grants and aid to county health departments. You know, it's a funny thing, Mr. Chairman, but prevention is difficult to see until it disappears. And then what you see is not always pretty. So please, don't let preventative health programs disappear in Georgia. Thank you.
Thank you, Scott. Greg Harry and Dave Ziles. That's number 11.
What does it get? Okay, here, let me hang on. Hello, can you hear me? Okay. Thank you for the committee for taking time to listen to me speak on behalf of the Independent Care Waiver Program and what it does for me and what it does for those who should be on it. My name is Greg Harry. I'm 47 years old today. 20 years ago, I was paralyzed in an accident that left me quadriplegic. I got on the Independent Care Waiver Program in 1992 with a waiting list. And it was fall of 1995 I was able to get benefits. I got 8 hours of help a day, and I got my disposable medical supplies paid for, and it was a real blessing. Before I was hurt, I'd been working for a small business that my next-door neighbor had started since the age of 14. I was 27 years old, and I was able-bodied, tax-paying, working individual, making the best of life, liberty, and the pursuit of happiness. And this blessed country of ours, when an accident on September 14th, 1991, left me paralyzed from the shoulders down. I'd been a musician for 15 years before my accident. Because I've been able to live in my community, I was able to learn about digital recording. I've been able to make music again. I've done my own records, and I've got other disabled musicians I bring in my studio and do recordings for them also. The waiver was set up to help those of us who are more dependent get the hours that we need, while those that are more independent get the few hours that they need. And it might all end up about even with money that it would cost for patients to live in nursing homes. Instead, the money would be used to allow them to live in the community. We've come a long way since the program was set up. And I would like to speak about the 163 people that are on the waiting list that could be unlocked. And I do have a spare bedroom in my house, and I'd gladly give that room if it would suffice somebody that could take their money that's keeping them in a nursing home to come live in their community and live in my house. And that's about all I have to say, and I appreciate your attention.
Greg, thank you for being here, and thank you for spending part of your birthday with us today, too.
You.
We're glad to have you. Happy birthday to you.
Thank you.
Dave Ziles.
Mr. Chairman and committee members, thank you very much for the time today. My name is Dave Zillis. I live in Sandy Springs, and I'm here today as a parent of a 32-year-old son that has Friedreich's ataxia, which is a degenerative muscle disease, who's been on the independent care waiver since 2009. And I'm also here to represent the 163 people that are currently on the waiting list that couldn't be here to talk to you. I want to thank you for your support in the past for these very important human community-based waivers that allow individuals with physical disabilities and traumatic brain injuries to remain in their homes instead of being placed in nursing homes. I also want to let you know that I clearly understand that the issue with the 2012 budget is very severe, and to stand up here and ask for additional money to be spent when we're trying to cut costs is not always practical. My son John, like many of the other on the waiting list, needs help with his daily living activities like bathing, dressing, toileting, preparing food, and transferring. He's classified as requiring nursing level care and receives 8 hours of personal care a day, 5 in the morning and 3 at night. He was living independently in his own place until the economy took a turn, and he's now living at home. But unfortunately, due to his disease, he's unable to work, but he really enjoys being able to live in the community, doing what he wants when he wants. He went to school, graduated with a degree in psychology. But John is like many of the other individuals on the waiting list. He was being taken care of by his parents, who are both in their 60s, and possibly may or may not be able to take care of him due to their own physical issues or the fact that they have full-time jobs. I find it very interesting in today's age that I can pick up the phone and within 30 minutes call and probably have John placed in a nursing home, and nobody asks about the cost or whether that's the right thing to do, but it just seems to be the thing that is most likely to happen. And yet when you want to try and stay at home, and like you've heard from Andrea and Greg, you've got to be put on a waiting list. I stand here before today asking for your consideration for 163 additional waiver slots. The cost of that request is about $2.7 million. Why would I even consider doing this during a year when we're having such a funding issue? The reason was in 2007 there were 152 slots allocated. 2008 there were no slots. In 2009, you're very appreciative to offer 75 slots, which eliminated the waiting list that year, and was actually the year my son went on the list. But as you heard earlier, there is no slots in 2010, 11, or now in the 12 budget. These waivers mean everything to the individuals and their families. It allows them to live independently, enjoy their life, as well as allowing their parents, typically their caregivers, to work and enjoy their lives too. I thank you for this time and respectively ask that you possibly consider putting some additional money back into the budget to handle this long waiting list of 163 individuals. Thank you very much.
Thank you very much. Martha Phillips is next, and then Linda Lowe.
Mr. Chairman and members of the committee, thank you for giving me the opportunity to speak to you today. And I know you've already heard about the dental issue from several other speakers before me, so in the interest of your time, I will be very brief. I'd just like to remind the committee that the only coverage for adult coverage is for pain and suffering except for the pregnant women. If we eliminate the service, the dental service for dentistry, these people who have horrific toothache pain will have to go somewhere else. And because the service is being eliminated and not the provider, if they go to the hospital or the physician, there's no place that these people are going to get relief from this horrific pain. We do know that in Maryland, Diamante Driver, a 12-year-old boy, died from a tooth abscess that went to the brain. Maryland really removed their adult coverage several years ago, and immediately after that they had an adult who died from an abscess that went to the brain, and the same governor who removed it signed the bill the next year to put it back in. I know all of you know the issue of dental, and I would just ask you strongly in this very difficult time to consider some way to put adult coverage back in. Thank you.
Thank you, Martha. Linda Lowe, and then Robert Geller.
Mr. Chairman and members of the committee, thank you so much for this opportunity today and for hearing us all out. Families First is the leading nonprofit family service agency in Georgia. We provide individual and family counseling, specialized foster care, adoptions, training in independent living skills, and advocacy on behalf of families. We're not directly engaged in providing health services, so none of this has anything to do with our budget. But access to health care has of necessity been a priority for us because of the families we serve. Every day, our staff members serve parents and children who are confronting life crises, and part of what they need is access to health services. And we have great difficulty finding that sometimes for them. We had several items that we wanted to talk about in relation to the 2012 budget today, so I'll go through those quickly, but there's plenty more to discuss in detail as we get a chance. One item is the crying need to streamline the Medicaid and Peach Care eligibility process so that children don't bounce back and forth between Medicaid and Peach Care. I know you all know about that issue. We've been working with Representative Gardner's work group that you've appointed on that, as well as on the proposal to go to 12 months of continuous eligibility so that children do not fall off Medicaid temporarily just because of paperwork. We know that thousands of children each month fall off for those kinds of reasons, and of course their care is interrupted. We'd like to see Georgia make a focus on getting the bonus money that we know that DCH is working on, that is available from the federal government, to reward states for increasing the number of children who get Medicaid and Peach Care and stay in Medicaid and Peach Care. And we are very much supportive of the money to revise the eligibility system, so that we hope you'll support that funding in the bond budget. A second issue is the Peach Care co-payments. We think that these are a problem mainly for those families who are at the low end of the Peach Care income scale. As you probably know, more than half of the children in Peach Care actually have incomes below 150% of poverty. They are not up at that high end of the scale, and many of them are just over poverty. We're concerned about the access issues that may be created there. Also, here's something we've been talking with the Department of Community Health about, and we're not sure what the deal will be. But the federal government requires that states assure that children's cost sharing in premiums and co-payments does not go over 5% of the family income. We're not completely clear whether the state is going to need to track this, but if it does, then that's going to add an administrative cost that could quickly erode this $1.5 million in state savings that you may be anticipating from these co-payments. It really would not be very difficult in a month or so for families at the low end of the scale to go over that 5% limit, especially if they have a hospital stay with that $50 co-payment, or if several of the children are sick at once, which I know all of you know happens. Again, the savings is only $1.5 million in state funds, but that costs us well over $4 million in federal funds that could be used to pay providers. We're also concerned about the elimination of the dental, podiatry, and vision services for adults. We know that you already have heard a lot about that, but we're also concerned, and also about the 1% cut in the provider fees, all of which affect access. We do want to thank you for putting money back in the budget for the health departments. That's also an access issue for us. Thank you for doing that in the 2011, and we hope you'll consider that again in 2012. Finally, we, like everybody else here, knows exactly what we're dealing with this fiscal crisis that we're in. But we think that it's time to have a different balance. We've done the kind of budget cutting that can be done. We now cannot provide some of the essential services that need to be provided in this state. We hope that you will enact recommendations from the Special Tax Council after making some changes on to make it a little more fair for middle and low-income families, and also increasing the tobacco tax so that we can make the kinds of investments that we need to make in Georgia to secure a healthy future. Thank you very much for all that you're doing and for letting us speak.
Thank you, Linda. Dr. Geller, and then Jeff Graham.
Good afternoon, Mr. Chairman, members of the committee. Thank you for hearing us. We represent the Georgia Poison Center, which is the poison center serving the state of Georgia. I have with me Dr. Gaylord Lopez, who is the center's director, and we want to comment to you about the situation that 2 years ago we took a budget cut in the switch to more federal stimulus dollars, and we're having difficulty having that restored.
Mr. Chairman, good afternoon, committee members. My name is Gaylord Lopez. I serve as director of the Georgia Poison Center. I am a pharmacist by education and have been so for the last 22 years, director of the center. Since 1970, the Georgia Poison Center has been providing toll-free poison center services to the state of Georgia. Our efforts have dramatically reduced healthcare costs over the years. How are we doing that? We're doing it two ways: preventing unnecessary emergency room visits and unnecessary doctor visits. In 2010 alone, we saved Georgia probably over $40 million, $10 million of which would have been a direct expense to Medicaid or other state programs. We're fortunate in that with our phone service, nearly 9 out of every 10 calls that we get were managed at home. And if people didn't have these valuable services, they would be going to our colleagues in emergency rooms and other office, doctor's office visits. So we think we play a unique role in the healthcare delivery system here in Georgia.
So we operate under federal cost sharing, and the federal government puts certain obligations on us as well. We are required to maintain certain staffing with certain types of people, pharmacists, nurses, and physicians that have real cost attached to them. We don't operate with secretaries answering the phones or clerks. And as a requirement, we require restoration of our budget back to the level we were. We have taken approximately 15% budget cut 2 years ago, and the restoration of funds proposed in the FY12 budget is only partial to match the stimulus money that was partially restored back then. Also, in addition to the services we provide 86,000 times a year to every residents of every county in the state, we also are a source for collecting this data and sharing with public health so that public health problems can be recognized before they get a chance to mushroom into a much larger problem. So we know that your time is short. We would be glad to entertain questions or provide further information at your discretion. Thank you.
Thank you both very much for being with us today. Next, Jeff Graham, and then Jeff Cornett, I believe it is, hemophilia of Georgia.
Thank you, Mr. Chairman, for the opportunity to address you today. My name is Jeff Graham. I'm with Georgia Equality, and we run the Georgia HIV Advocacy Network. I would like to talk to you today about the AIDS Drug Assistance Program, an issue that came up during last week's testimony from Commissioner Cook. The AIDS Drug Assistance Program is jointly funded through federal and state dollars. It currently serves about 4,300 people. These are all low-income individuals living with HIV and AIDS who have no other source of paying for their life-saving medications. In 2009, there was a 17% increase in the demand for this program. The department did their best to stretch those dollars, but in July 1st of last year, they had to start a waiting list for this program. As of today, that waiting list is now up to 1,008 people, and it is growing on average of 30 to 40 people every single week. The total projected shortfall in fiscal year 2012 for the program is set at $15 million. We do hope and expect that there will be additional federal dollars that will come to the state of Georgia later this year. We expect that that will be $10 million from the federal Ryan White program. The department is also currently looking at a number of ways to be more efficient with the program. We believe that these efficiencies will also save $2 to $3 million off of the program, but that still will leave us with a budget shortfall of between $2 and $3 million to be able to adequately serve the people who need this program for their medications. It's important to keep in mind that just with many other programs, the access to medications for these folks, if they don't have other guaranteed access, they will develop costly medical conditions. Right now, the annual cost of care for people on the AIDS Drug Assistance Program is less than $10,000 per person per year. However, if these people do get sick, and without medications they will get sick, annual cost of hospitalization and chronic care can easily top $150,000 per person per year or more. Our system just cannot handle those costs further down the road. We appreciate that this is an extremely difficult budget year, once again, for you all. However, we do appreciate any consideration that you can give to addressing the problem of the AIDS Drug Assistance Program in the 2012 budget. I would now entertain any questions if you have any.
Yeah, thank you very much. Appreciate you being with us today. Jeff Cornett, I think.
Yes, Mr. Chairman and Committee. Thank you for this opportunity. I am Jeff Cornett. I've worked with Hemophilia of Georgia. I've been a nurse for over 20 years working with the hemophilia community. And I'm probably the only person you're going to hear from today that's going to be happy that our budget has been cut. The program cost $1.8 million in the last fiscal year to provide medication for people with hemophilia. With the availability of the pre-existing condition insurance plans, we've been able to take that program much lower in its cost, saving the state well over $1 million. In the budget, for the amended budget, we were very kind to put us back in $250,000 because it was taking us some time to get people signed up for the program. That's not going to be the issue in the next fiscal year. The issue in the next fiscal year is that people must be uninsured for 6 months before they can qualify. So if we have folks who exhaust their COBRA benefits that we've been paying for, they have to get medication then for 6 months, be uninsured before they can qualify for the pre-existing condition insurance plan. That's the worst case of having to provide medication for that time. The next, if we have people move into the state, we are requiring people, if they're uninsured, to sign up for the program. But it takes us, in best case scenario, about 2 months to get people signed up. So we have people in there. So we need about $250,000 more than what is called for in the budget to be able to get everyone signed up and cover the cost. We've given you a detailed budget there. We've also supplied that to the Department, to Public Health, and to the House Budget Office, and we'd be glad to answer any questions. We are continuing to look at how we can reduce costs. As Jeff Graham spoke about ADAP, cost of state money, we have at least 2 people on this program that are on ADAP. Because we've moved into pre-existing condition insurance plan, we're going to save the state about $18,000 there. So we're trying to take advantage every way we can, and we appreciate your assistance.
Yeah, thank you. The last person I have on my list is Karen Batchelor.
Ooh, aren't you glad I'm the last one? Good afternoon. My name is Karen Batchelor. I'm a retired registered nurse and a legislative volunteer for the Georgia Council on Aging. I'm here to express our concern about the elimination of the Medicaid coverage for adults for podiatry care. This critical medical service is vital to the health and well-being not only of persons with diabetes, but also older adults and others with impaired circulation, disabling arthritis, cardiovascular disease, and other health conditions which prevent them from providing their own personal care safely. Podiatry care is not provided by family physicians, internists, or other frontline physicians, and we cannot expect that they will fill the gap.
Without proper foot care, individuals with the conditions mentioned earlier often experience difficulties such as impaired mobility, infection, and other acute problems leading to emergency room care, hospitalization, amputation of limbs, institutional placement, and even death. The cost of any of these alternatives far exceeds the cost of preventive podiatry care. Medicare and many private insurance policies follow a preventive care model, which we hope that the state of Georgia will continue by funding Medicaid coverage for podiatry services. The savings achieved by terminating this care will be outweighed by the cost in human lives and the increase in Medicaid expenditures and uncompensated hospital care when the care is provided at a more acute level. Thank you for your consideration.
Thank you, ma'am. Thank you for being here. This is everyone that signed up on the list that I have. Is there anyone here that did not get on the list that wanted to be heard? Yes, ma'am. Please. If you would, tell us who you are. And
my name's Shantae James, and I'm a third-year pediatric resident at Emory who'll be finishing up my residency in June. And I'm in a position where I'm starting to look for jobs and deciding where I want to be. And a lot of the people that are in my program are in that place as well. They're like me. They're single. They don't have any kids, and they really don't have a necessary tie to stay in Georgia, but we're looking for one, and we want to be pediatricians in Georgia. We want to be encouraged by what you guys are doing with the Medicaid reimbursement. And I just want to encourage you guys. You guys have heard hours of testimony kind of about what's going on, but I want to encourage you guys that we're hopeful, and we're watching the legislation, and we're just hoping that we can find jobs that are in Georgia, stay in Georgia, and be encouraged by legislation that's supporting us in our efforts to find a good job that's going to be supported by Medicaid in Georgia. And that's all. Thanks.
Thank you. Thank you for taking your time to come down and share that with us today. I want to thank all of you out there in the audience who have been with us all day. We're thinking about having a drawing for all of you that are still here. We're going to give away a bottle of water or something so that we could thank you for being here. And I apologize to any of you that I didn't pronounce your name properly, but again, we want to thank you all for staying and your interest in what we're doing. I assure you the members of this committee take this very seriously, and as you have heard, there's been a lot of needs expressed, and the problem, or the answer, I guess, to all of those is the money. So we're going to look at it and try to do the very best that we can along those issues. Is there anyone on the committee that would like to have anything to say before we adjourn? Well, thank you all again for being with us. We appreciate what you do.